evaluation of aortic stent endoleaks using ferumoxytol enhanced MR angiography. No disclosures, just note the use of ferumoxytol for MRI is considered off-label use. Ferramoxitol enhanced MR angiography is accurate for aortic mapping prior to TAVR and has been suggested as a sensitive method to detect endoleaks following EVAR. Endoleaks are present in up to 25% of EVARs at the time of repair. Some are associated with increased sac pressure and risk of rupture, your type 1s and 3s. Not all endoleaks require treatment, however, but they do require surveillance, your type 2s. Just a review on endoleak types. Your type 1A and B superior and inferior aspect leaks. Your type 2, typically retrograde filling from an iliolumbar or IMA. Your type 3, between components leak at the contralateral gate or fabric. Type 4, porosity, and type 5, endotension. 1 month baseline imaging is obtained after EVAR. If type 1 or 3 is seen, you typically re-intervene. If type 2 is seen, which is most common, a 6-month follow-up is done to look for sac growth. If no sac growth, Q6-month imaging up to 24 months for surveillance. So what are your modalities for surveillance? Ultrasound, CTA, and MRA are all possible modalities. CTA and MRA are preferred as they're both sensitive and specific and provide more information. MR can be done with gadolinium or with ferumoxytol. So why ferumoxytol? Well, in contraindications to gadolinium or iodine-based contrast, such as chronic renal failure or allergy, it's theoretically more sensitive for slow leaks as it is a specific blood pool agent. There's no need to time the bolus, and there's less potential acquisition issues with breath holding. So you can repeat the breath hold re-image without contrast redistribution. And it has been described before, which we'll get into later. So the purpose of this study was to evaluate the feasibility of high-resolution ferumoxytol enhanced MR angiography in the detection and categorization of aortic stent endoleaks following EVAR. This was a single-center retrospective study with patients post-EVAR having chronic renal failure or allergy. There were 4 patients in total and 6 studies in total. All patients were 68 to 84 years old with a complex medical history, including CKD or ESRD, all with AAA status post-EVAR and either a persistent known leak or prior failed or attempted repair that was undergoing re-examination. As far as technique, the contrast we used was Feraheme at a dose of 4 mg per kg. The initial dynamic study was 1 mg per kg of dilute contrast injected over 10 seconds. Slow infusion of the remainder over 6 minutes to a total dose of 4 mg per kg. Intermittent repeat acquisition over the first 3 minutes, then at steady state, and delayed imaging as needed, which we did not do. The MR scanners were Siemens, majority were 3 Tesla and 1.5 Tesla. Multiplanar pre-contrast and post-contrast haste, T1 vibe, and high-resolution breath-held 3D MRA for the sequences. Pre-contrast imaging is important to differentiate thrombus or prior embolic materials from endoleak. Post-processing was done on Osirix and Vitreous softwares. So all 6 FE-MRA examinations were technically successful and diagnostic in the immediate identification of aortic stent endoleaks. The site of endoleak was identified on early steady-state imaging, and no patients required delayed imaging for diagnosis. There were 3 type 1As, all in a single patient with 3 exams over 9 months that consistently demonstrated a stable large endoleak from the superior aspect, 1 type 1B from a poorly sealed right common iliac limb, and 2 type 2s from retrograde filling from an IMA and lumbar artery. No immediate or delayed adverse reactions were observed. Here is a coronal post-contrast with a large type 1A endoleak coming into view. You can see the large sac here at the superior aspect of the graph, this being the remainder of the aortic body and the iliacs. This was stable over 9 months and 3 examinations. He was not repaired for other reasons. Here is a large type 2 leak with avid filling of the sac that you can see here. And this was from retrograde filling from an IMA. These are color volume rendered images processed on Vitrea with all the vessels visualized, systemic arteries in red, venous in blue. You can also see the pulmonary vessels and portal venous system. Each vascular bed can be segmented and removed in the processing software. And here we see arrows pointing to the type 1A leak in purple and the type 2 leak in green. Another coronal Post-contrast with a type 1B, focus on the right common iliac limb. You can see contrast starting to pool here at the inferior aspect of the graft. Similar color volume rendered images. Note the tortuosity of the iliacs and the texture of the stent, which is seen very well, and the type 1B leak in green. Another representation of the same type 1B leak. The white haze around the patient is actually the skin, so a very large patient, but still able to get good quality graphics. So what has been shown before? Urso in 2004 looked at ferumoxytol MRA in 6 patients. They showed the location, volume, and rate in 4 patients in arterial and delayed 8 to 23-minute images, and in all 6 patients on delayed 24-hour images with MRA, compared to only 2 by CTA. Ichihashi, with a nice study in 2013, compared 23 patients after EVAR with CTA and MRA with ferumoxytol, finding 11 total endoleaks, more of them with MRA, 8 leaks by CT and 10 by MRA, all type 2 endoleaks. And here are some images on the top right from their study. So what did we show? We showed that dynamic imaging showed the exact location of endoleaks and eliminated the need for delayed imaging in our preliminary study, though delayed imaging may still be useful for slow leaks as previously shown. More endoleak types were identified and definitively distinguished. Prior studies were type 2. We used a higher field strength and higher dose, which resulted in a higher SNR, and volume rendered images were illustrative and confidently portray the endoleak. And again, why ferumoxytol? Whether there are contraindications to gadolinium or iodine-based contrast, such as chronic renal failure or allergy, it's theoretically more sensitive for slow leaks and is a powerful intravascular agent. There's no need to time the bolus, and again, less potential acquisition issues with breath holding. So you can re-coach the patient and re-image. Limitations included a small sample size and applicability to all institutions. So in conclusion, in patients with history of EVAR, ferumoxytol enhanced MRA is promising for safe and effective evaluation of aortic stent endoleaks. Dynamic imaging may evaluate the exact location, potentially evaluate all types, and potentially obviate the need for delayed imaging. And future investigations with larger populations are still needed. Thank you very much.